Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even few are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.
Welcome to VITALS, Visionary Health Leadership in Action. VITALS is an open forum to engage in frank discussions with the nation's most innovative healthcare leaders using VITALS: value, innovation, leadership, advocacy, and service to address our biggest healthcare concerns. This evening, we are honored to hear from a healthcare leader that is using advanced technological solutions to create new solutions to healthcare's biggest problems. Dr. Mehool Patel serves as Associate Chief Medical Officer for IBM's Health Officers Pursuing Excellence and Evidence, or HOPE team. Dr. Patel previously served at IBM's Client Experience team and in medical affairs, where he worked with IBM's development, design, and regulatory teams focused on life science and provider analytics. He is an expert in artificial intelligence and its applications within healthcare, and has worked with ministries of health for improvement in population health. Dr. Patel is a board-certified medical oncologist and hematologist who practiced for 15 years at Summa Health Systems. He earned his Doctor of Medicine from Northeast Ohio Medical University and obtained an MBA in healthcare finance from Auburn University. Dr. Patel remains active in medical education and is the section chief and chair of hematology and course director and co-director for several classes, including Foundations of Disease Treatment, Clinical Informatics, and Technology at Northeast Ohio Medical University. We are honored to have you join us tonight. Welcome, Dr. Patel.
Thank you, Dr. Langell and NEOMED and Monica for this opportunity to speak to you this afternoon in the VITALS program. As an alumnus, it truly is a privilege to be able to talk to you about one of the core elements of VITALS, T technology, and recognizing it as a key backbone in value-based care and innovation, as well as to afford the advocacy, leadership, and service within healthcare. Now, when we first think of technology, our mind conjures many different things. This slide represents maybe three of the more common themes. We see in the upper left corner, the robotics and the possibilities, but we also have concerns that it could supplant physicians in fields such as radiology or pathology. In the bottom left field, we can see the wonderment and awe and hopes that technology can improve patient engagement, improve clinicians' clinical outflow, therapies and treatments, as well as allowing for the advancement of the business of healthcare itself. On the right side, I think, is what we probably experience the most, the frustration when we have to wire or rewire computers, or the ire we may face when new technology is thrust upon us in our clinical practice that upsets our established practice modes. On this slide, we can see where the strengths of humans and artificial intelligence is. Artificial intelligence allows for easy pattern identification, bringing the key data quickly to us. It's very consistent and typically, though not always, reduces bias. Humans, we excel at abstraction, imagination, and compassion, and with always an emphasis on moral action. On this slide, we see the vast quantities of medical information that's available and only growing exponentially, from the volumes of books a patient will produce in their lifetime to the explosion of medical literature that a clinician needs to be cognizant of. This is compounded by patients living longer, having more chronic ailments, and unfortunately, even increasing amounts of clinician shortages. Each patient will generate 300 million books of medical data in their lifetime. And in 2020, 44 zettabytes of information, medical information was generated. Now, I'm sure no one knows what a zettabyte is, but 1 zettabyte is 1 trillion gigabytes. And if we wanted to make an equivalency to 44 zettabytes, here's what that would be equivalent to items that we can easily identify. So how do we handle this deluge? We need to use technology to understand, reason, learn, and interact for our needs. Now, recognizing that this is a very broad topic, I'm going to focus in just on 3 areas and where the AI intersects with healthcare. And then I'll get back to the VITALS acronym and talk about leadership and some predictive analytics. The first example is radiology imaging. I think we can visualize the concerns, but every year in the United States, there are 800 million radiology exams performed annually. This is exams, not individual images. And we know that CT and MRI exams may have dozens or hundreds of images for each exam. Now, looking at the time a radiologist spends on non-clinical tasks, coupled with the radiologist shortages that we currently have, which is expected to worsen to 42,000 by the year 2033, imagine how much starker that is in less developed nations, or even other westernized nations such as the United Kingdom, where the shortage is critical currently. This is not simply a solution of using third parties either domestically or internationally to solve the delays. This is an area where we need to look beyond, and this is an area where technology, AI can help ameliorate the worker shortages from radiologists, but also the massive deluge of images that they experience on a daily basis. In this example, we see the potential for the radiologist to miss an obvious finding. This study showed 20 of 24 radiologists missed seeing the gorilla that was superimposed on the CT of the chest when they were screening for pulmonary nodules. On this study, we see 8,200 plus scans that were reviewed by the radiologist deemed negative for pulmonary embolism. The AI reviewed all those scans and found that 154 were of concern. And of that, 24 were found by the radiologist to truly have PE that was missed initially, about 16% of the total. So what does this tell us? It tells us that 24 patients should have had PE-directed therapy, but it also tells us 130 scans were brought back unnecessarily to the radiologist for re-review. Now, how does this help us if unnecessary tasks are being brought back to us? Well, we know that as the AI solution becomes more sophisticated, and as it becomes more sophisticated, and as we know that the solution will become more accurate with more precision modeling in its deep learning and machine learning modeling, we know that less and less of these non-relevant scans will be brought back to us to be re-reviewed. But critically and most importantly, the review of 8,200 scans took less than a few minutes versus the scores of hours an individual radiologist would have to review those films, or even a team of radiologists. We continue to see the power of the AI on this image of a CT scan of the abdomen with the liver focus. Here, the liver lesions are outlined by the AI machine. Size measurements are given, and though not clearly shown on this image, it even has the capacity to detail the characterization of that lesion from something that could be malignant, other abnormalities of concern, or a completely benign process. The power to pull up old scans and continue to outline and show any changes between lesions is time-saving for the radiologist, which is critical for diseases such as a metastatic colon cancer to the liver, where you need to know if there's progression to either change therapy or if there's improvement of disease where you can continue that same therapy. On this image of the MRI of the prostate, we see the teal blue color in the upper left image where the AI has outlined the gland. But we also see in the yellow an area that's been identified as prostate cancer. Now, to be able to do this, there has to be some ground truth for the machine to know. So this is an image of ground truth where the red shows the AI outline of the machine and the green is the radiologist, which may be a little bit more difficult to ascertain. This is one of hundreds, thousands, tens of thousands, or hundreds of thousands of images that need to have ground truth to make that modeling for the AI to be accurate and precise for use. Now, going back to that prostate cancer with a little bit more zoomed up view, we can see not only is it reporting to the radiologist the prostate cancer, but it's also showing the extent to the invasion to the adjacent anatomical structures to further inform the radiologist. They can look at that, review it, concur, and then report that out accordingly. Now, this is not only important for the radiologist, but the treating physicians as well. The urologist, the radiation oncologist, because it will determine what's the most appropriate therapy for that prostate cancer patient. Now, the growth of AI technology and imaging is really in 4 key areas. It's cardiology, neurology, pulmonology, and breast, about 86% or so. Liver and prostate are expected to grow tremendously over the next few years. The FDA has approved some review process right now that augment the review process, but not fully automate the entire process. In 2018, they did approve the Viz AI contact application, a clinical decision support solution that informed providers of a potential stroke in patients with large vessel blockages on CT brain images. Also in 2018, they approved the IDXDR solution, which allowed non-experts to recognize diabetic retinopathy with an informed recommendation for consult ophthalmology for confirmation. So when we look at AI in radiology and imaging, it's very similar to the second example, which will be pathology imaging. And the reason they're both very similar is the machine learning and the deep learning algorithms used for the model are very similar, which is true across the entire imaging format. Some of the advantages, though, of imaging in general with technology and why they're very compatible. One is improved efficiency. It will reduce the amount of time that pathology specimens or radiology images have to be reviewed. And then it can also bring the more concerning cases to the forefront and highlight that to the clinician reading either the slide or the image on radiology. Second, it allows it to expedite that process so they can actually spend more time on the concerning cases. The AI system could flag areas of concern or flag an entire case for immediate attention. And the third example is it improves positive workflow changes. And this is exemplified by the pathology example from the Alina solution. This is the lymph node assistance solution from Google, where they looked at breast cancer spread to the regional lymph nodes. Now, just to set a cap here, when you have breast cancer spread to the regional lymph nodes, it can dramatically alter the recommendations when there's surgical, chemotherapeutic, or radiation options. On the right panel here, you can see the bright red is what Lina has outlined as the cancer within the regional lymph node on the specimen. It corresponds to the left panel there. It's the lighter purple shade near the center of the larger chunk of tissue. Now, on the next image will be low power with increasing magnification. The next slide will show a very small amount of metastases on the entire slide. And remember that if there's a small amount, it's not obvious to the pathologist, and they have to do a methodical slide review in a methodical fashion to make sure they don't miss anything. And we know that if there's small metastases and the pathologist is very rushed, the detection rate is about as high as 38%. So Lina has produced these results, and Google presented in one of their publications that it had a 99% accuracy for the detection of metastatic disease to the lymph nodes. And you can see in the blue, eventually, it highlighted the area of metastases on that entire slide. Now, Google also reported that the pathologists using it really reduced the amount of time that they were spending on slide review. And when it was small metastases, the slide time was cut in half. So when we look at imaging, the benefits I kind of mentioned in between the two examples, but just to recap there a little bit, this really does improve the clinician's workflow time and how they do process their specimens or images, but it also gives a detailed data review that allows for more accuracy and fewer errors, which not only benefits patients, but I think also benefits the clinicians in their daily practice. I want to give you a third example. of where there's been some benefit. And this is something known as external control studies in clinical studies. We know the challenges with clinical studies. There's complexity of the study, there's spiraling cost of the studies, patient access and enrollment, the hesitancy to use new technologies to make those trials more successful. We couple this with the difficulty with trial sites not meeting their enrollment goals. About 50% miss their goals. 70% of trials are delayed due to recruitment problems. And even more concerning is that the clinical trial dropout rate, meaning those patients that dropped out of clinical study before expected, is about 30%. And then we also look at the difficulties of rarity of diseases. That also adds complexity. And where AI can help here is this external control arm. So in the next two slides, I've given a visual demonstration of this because I think it would be easier to understand. When we look at this slide here on the left is the treatment arm, and patients are enrolling exactly as you would expect, randomized to the treatment arm. But on the right side with the lighter gray shading boxes is the control arm or the standard arm. And you can do one of two things. The entire control arm can be from an external data set, typically an old study that had similar scope and size, and you bring that into the control arm. Or you can do what this slide exemplifies, which is the hybrid fashion, where half the patients come from this cohort and half the patients come from a randomization into the study as would be expected in any current standard study. Now, a nuance of that is that your previous data set, the previous trials may not be similar in scope. So you have to go through multiple studies to find the right patient with the right demographics and the right disease status and create this simulated patient pool. And what you do is you run them through matching microsimulations over and over and over again until you achieve the right cohort. Now, what are the benefits here? There's basically four major benefits of this. And this, before I even do that, this was first used in 2002 by Dr. Etzioni and colleagues when they were looking at PSA screening to prevent overdiagnosis of prostate cancer. And that was published in the JNCA back then. For drug therapy, the first time it was used, I believe, was 2010 with a rare disease called Pompe disease with two drugs, myozyme and lumazyme. And what they did is they proved overall survival in the patients enrolled in the current study based compared to an age and disease matched historical controls. Now, very few drugs in the last decade have moved on to this process, and there's been a push in oncology to move it there. And there's four real reasons why this is beneficial. The first reason is what Roche did in the European Union to get accelerated marketing approval for their drug Alcensa, which is a chemotherapeutic agent, for a pricing decision to meet EUA regulator approval. The second is what Amgen did to accelerate the labeling expansion for their drug Blincyto, which is for B-cell acute lymphocytic leukemia. The third is what Pfizer and Merck KGaA of Germany did to assess the efficacy of their PD-L1 inhibitor, Bavencio, for a rare aggressive Merkel cell carcinoma by looking at EMR data from EU and US records. And the fourth is what Metadata has just done to expedite the research to show that their new study for phase 3 glioblastoma multiforme can be run. And what they did is they engineered the historical control arm based on 22,000 previous studies of phase 3 GBM, which is a remarkable feat to go through that many studies to find the right patient cohort to achieve that. So these are three examples, and I know they were quick, and I apologize for not going in depth of the detail, but these are three examples of where AI and technology really intersect. And I do want to go back to leadership and talk about how, and that's the L in VITALS, and how leaders see or use AI within their institutions. First, I think it's very important to remember that I think leaders need to be cognizant of the full scope of what technology is, not just an IT wiring issue. And those leaders who have a very robust understanding will probably make key and critical decisions that will really advance their institution. We've talked to a lot of executives over the course of these past few years, And what they all tell us is the IT, the data, the tech issues, those are the issues that keep them up at night. And it's very understandable. There's a lot of cost association here, and it's not clear the investment they're making really will fix the pain points they have within their institutions, or even allow for institutional relevancy within their market. But I think leaders who harness the power of their data can really make substantial and formidable changes for their institution. To be able to do that, though, they have to know the breadth, the depth, and the quality of their data. And a lot of data within healthcare is unstructured, meaning that it's harder to extract and it's harder to utilize and it has more cost. But if you do it very well, I think the rewards are immense. This next example shows an example of that. Using predictive analytics, the folks at Mount Sinai in New York City took all the data coming into their warehouse on all the patients, and they were able to accurately predict which patients would develop which diseases in the future across the spectrum. Imagine predicting which patients in your institution could develop diabetes and having an early intervention with dietary or nutritional consultation, or even diet and exercise programs. The long-term cost savings there alone would pay for the programs up front. And in this example, as exemplified, is the cancer. Could I identify cancer before they develop it or maybe at earlier stages? We know that treating a patient with an early stage malignancy has far lower cost. And more importantly, it offers the patient a long-term chance for cure and survival. Now, some of the EMR systems are doing this, but I think being forward-looking and being innovative can really move your institution way past what the EMR can do for you. But to do all of that requires a change mindset. And a change to a data-centric approach. And I think an innovative, insightful leader with a smart partner can really push their institution to become the leaders within their market. One last thing about leadership I want to talk about real quickly is having a full recognition that their healthcare workforce across the spectrum does not have the background requisite education in IT, tech, data science, blockchain, and so forth. To have a workforce that understands the process, understands the applications being used, will be a workforce that will be more accepting and trusting of the technology and the careers that they move on to. And in this field, it's healthcare workers and eventually the outcomes of patients. At Morehouse College, they are now mandating that all students, regardless of degree, have some form of background education in data science. So I hope I've given 3 examples briefly here, and I'm sorry that it was short, but where AI and technology intersect. From the pathology and radiology imaging, I think it's more tangible. We can see where the benefits really lie. With the 3rd example, we saw how AI has the power of patterns of, you can see the patterns of repetition and how it can be used to improve clinical trial success. Looking at leadership and how they see AI will basically determine how their institutions do accordingly. And so when we look from the C-suite concerns of financial and operational accountability, to the clinician's improvement of workflow and outcomes, to the pharmaceutical desires for research prudence and drug development success. Again, 3 of the examples where AI and technology can intersect. And I think I went over by a few minutes. I do apologize. So I will turn it back to Monica. I did like to talk a lot with patients, so my habit continues, unfortunately.
Oh, Dr. Patel, don't worry. We have a whole bunch of questions for you already. So if anybody else in our any of the attendees would like to ask Dr. Patel a question, just put it in the Q&A section and we'll be able to ask those questions for you. So the first one is from the audience. We see that AI picked up lesions that physicians missed, but how often did physicians find lesions that AI missed? I'll start with that one first.
Sure. I mean, I couldn't give you an exact number. I know early on in an AI modeling, yeah, you're going to miss a lot because you have to have that ground truth, whether it's, lung scans or dermatology exam, ophthalmology, whatever it is from imaging, they're going to miss some. But I know presentations, if you look in the last decade, last 5 years especially, the AI machines, when the solution is refined enough, are equivalent or better than any of the physicians when it came to reading whether it's finding polyps on a colonoscopy. I think Dr. Arnetti and colleagues presented that several years ago in a publication in the gastroenterology field. I know you've seen a ton of dermatology slides where the machine maybe performs 10 to 15 to 20% better than the dermatologist in identifying melanoma lesions. But in the beginning, there's going to be some error, but you're never going to see a product on the market that has lower than equivalency to the physician. It's probably not going to get an approval from the FDA or some other regulatory agency worldwide.
You also talked, though, about cost. And one of the issues with cost is also the fact that we all know technology becomes obsolete. So how does, the head of a hospital justify this massive expenditure, knowing that in 2 to 3, 5 years that this monster computer is going to be obsolete?
Sure. So I think there's several ways to deal with that. And I actually just spoke with the CEO of a hospital earlier this afternoon. And one of their concerns was the cost. They were trying to develop everything or have everything on site for the storage, whether it's the infrastructure, the tech, all the wiring, whatever. And at some point in the conversation, he's like, if I had $100 million, I would basically outsource that to some other party. So do you need to store all that within your institution? Because if you're stored, like the images for the radiology, some images are 3 gigabytes each. And if you're storing all that data on site, you're going to have a lot of hardware and a lot of room somewhere of computer hardware that is able to store that much data, because that's just one image of one person's scan. So if you can put that in the cloud, you can use other technologies to allow you to offset some of that infrastructure cost. Maybe the technology becomes more affordable in the long term. You don't have to worry about the upkeep of that, at least. Our computers, we have to update them periodically. They do fall out of line, but I think whatever you can do to have a third party, reliable third party, store information for you in a safe, HIPAA compliant or GDPR compliant if you're the EU, I think that's what you probably have to look at. And very few institutions in this country or this world can do everything in-house. You have to be a massive behemoth to really do it all. And I think you have to find these smart partnerships where they lie to really be able to do that effectively. I hope I answered that question, Monica.
Yeah. As this becomes more effective and more accepted, how do we prevent overdependence on computers and loss of transferable knowledge to human clinician experts, and when and if computers are unavailable?
Well, those days are tough when you're in the office and the EMR shuts down. You have to find paper somehow to write things. So I think it's like everything. You have to have audits of what you do, right? You can't just rely on the technology being 100% accurate, because as a clinician, we know we're never 100% accurate. We always make some mistakes that are hopefully not noticeable, hopefully not major. So you have to be able to audit what you're doing. You have to do random audits. You have to do periodic planned audits. You have to ensure that the technology being used, that whoever's providing that technology is keeping up the appropriate verification and validation, the V&V process of their solutions. This is the development and design teams from whichever company produces your solutions are doing, a check on that to make sure that there's accuracy, that it's not being missed. But I think it's the responsibility of the physician. You're using this as an adjunct tool. This is not here to replace you. I think any tech company that comes in and tells you we're going to replace you is probably not the partner you want. You want a company to come in and tell you that we're here to assist and be an adjunct for the use, but you are the final decision maker, that we are helping expedite these reviews, but you're officially reviewing them, you're concurring with the findings. And I admit, when you get in a habit, you might be complacent, but I think it's on the onus of the physician and the institution where they work to make sure that there's proper auditing of how you use that solution.
How does medical education have to change or evolve to prepare future health professionals to operate in an AI environment?
Yeah, Dr. Langell and I, we've had a discussion about this. We need to have more data science discussions, AI, blockchain, quantum understanding that comes into the healthcare fields. And right now, it's there in business, it's there in finance, because those technologies are used far more currently in those fields. But in the healthcare, whether it's nursing, pharmacy, medicine, the allied health professionals, we need to have this discussion. It's not formal for many colleges. I can tell you from my own company, I know NEOMED has agreed to participate in bringing some of that education to the students here at NEOMED. But we've done it with some of the HBCUs, the historically black colleges. We've done that as well with Morehouse and others, where we're engaging and bringing this education to every student who wants it. And honestly, I don't know about I know Google doesn't offer this because I spoke with them in the past few weeks, but I don't know about Microsoft, but we are providing free education to students basically with using IBM solutions that you can use, to run research projects and do other things, so you can get familiar and comfortable with AI and also learn about blockchain and quantum and so forth. But it has to be brought in the education. Medical field cannot be aloof from understanding data science and this stuff.
Can you talk about the implications of the use of innovative technologies upon the charges that patients will ultimately see?
Sure. So, I don't know how CMS will rule on that, because they'll decide whether or not you can charge for something like that. And I can tell you just an example from the past. In 1998, I don't remember the solution name. There was a breast mammogram solution that was supposed to detect cancer better. CMS improved it, gave reimbursement, but in the long-term follow-up, it made no changes on the detection rate of breast cancer by using that solution, but it was a high payout. So I think cognizant of those kind of problems, those rare examples, the regulatory agencies are going to make sure if the solution's coming and we're going to reimburse for that, that it's going to be effective. Now, how you're going to charge as an institution, I know there's a price transparency that hospitals have to provide. I think the rule went into effect in January of 2021, though there's been some delay I saw this past week. And it's not clear the new administration will continue the policies of the former CMS director, but I think price transparency is where we're going to see it, because you're going to be an outlier if you're going to start charging for your technology. And I think if you're running thousands and thousands of scans or pathology images and using AI solution, the long-term use of it will probably pay for the cost. Based on the solution, will probably determine the number of years before you can maybe write that off as a cost. But I see it hard to charge patients directly. And a lot of the technology right now being incorporated into healthcare is something that patients are paying for. Right? It's the Internet of Things. It's the Fitbits. It's the Apple Watches. These things are a powerful tool when it comes to keeping track of individuals' health, and that stuff is getting incorporated directly into your healthcare records.
Can you distinguish between iteration and innovation, and what do you see as the next life-saving innovations in healthcare?
I think the next life-saving innovations in healthcare are going to be getting drugs approved and developed that we know are going to be helping diseases. The diseases will respond to the therapies being given. And I think that drug discovery is, I think, where the next real major frontier is, because I mentioned the clinical trials, but there's a huge dropout from phase 1 to phase 3, but even preclinical, there's a massive dropout of drugs in development. If you can get that right, it'll bring the R&D costs down, which hopefully will parlay, though, I'm not a pharmaceutical company, but hopefully will parlay into lower drug costs. But I think that's next horizon. And it's this complexity of drug development, the genomics, the single cell transcriptomics. I think this is the next horizon that we're looking at, where there's going to be major advances. It may not seem big from a day-to-day practice, but from a treatment standpoint and across the field, I think that's where the big issues are. And iterative just means to kind of reinvent that wheel. We do that all the time with design. Are we iterating? Are we making sure we're meeting? Are we meeting the challenges, the questions being asked, the needs that are in the market and stuff like that?
Is AI being used for the new PSMA PET scan for prostate cancer? And if so, how does one have the scan reviewed?
Okay. I don't know specifically about this MRI PET for prostate cancer. I know that our company is working on prostate imaging. I don't know specifically about this scan. Monica, can you repeat the second part of your question? I'm sorry.
1 second. If so, how does one have the scan reviewed?
Sure. So this goes into the development phase. It's that ground truth. Like I showed on MRI, it's the same thing. You have to have ground truth. And that could be hundreds, but typically it's thousands or tens of thousands of images that get reviewed, marked up by the AI learns from what the human does. The AI does it by itself, the human concurs, and that cycle goes on and on until they feel like there's enough accuracy that it would be appropriate to move it forward to a solution that can be marketed and brought forward before the FDA, before the marketing and stuff like that. It's a tedious process, and that's a lot of the cost of technology. When I first joined, I thought, oh, quick flip a switch. How hard is it to do this? This will make my life so much easier. It takes a lot of time for development to write that code to be able to be accurate and make the modeling appropriate.
You touched on this a bit, but we have another question. How do medical students best prepare to function in a world of patient care dominated by technologies they truly don't understand?
Well, I think hopefully, if you're a student here, you'll be able to have a chance to have some background in data science and AI and technology and those things. But I think it's important that you kind of go out and read. You pick up a clinical informatics book, or you pick up something on data science, and typically they're within the same textbook, and you maybe just go through it. Again, there are paid programs you can do, universities, but I don't think that's what students really want. I think it's really taking the time and effort, because when you go for orientation at these institutions, it's a 2-hour lesson, how to use the EMR and kind of set up your favorites, but it doesn't go into the depth. What is it telling you? How can I use this more effectively? How is this being brought to my attention? And there's a lot of technology that you're not aware of. There's a lot of blockchain that goes on in hospitals. All of that is AI, but it really takes an initiative and drive of an individual to go out until the medical schools or the medical field schools start adding this into their curriculum. It's otherwise pretty hard to do that. It's not going to be taught in a residency or fellowship.
Do you think at this point, though, this is just an absolute necessity if you want to succeed in healthcare at all?
I don't think it's an absolute necessity in the next few years, but I think long-term, to make you an effective clinician, absolutely. If you're the one who's more efficient, you're the one who's able to use the technology, not getting frustrated by what you're doing, you're going to probably be happier in the occupation you're at. You're going to be more productive. You're going to hopefully stare at your patients more. I think, when we went from paper to EMR, I think that was the biggest drawback, is you no longer stared at your patients. You had a clickety-clack on a computer, and it becomes distracting. But if you're efficient, where you can do minimal of that and stare at the patient and talk with them and look at them directly in the eye, I think that adds a lot of value. But it's a tough.
Are some health professionals better suited for the use of AI than others?
Yeah, right now, AI is really geared for radiology from a clinical standpoint of view. It's the radiologist, the pathologist, the dermatologist, and I'll even say the endoscopist, like doing EGD or a colonoscopy. Anything visual, I think right now is the most tangible examples that we have. But again, there's a lot of AI in healthcare that's not in a clinical front view. There's a lot of stuff behind the scenes that is definitely expanding. It's the analytics that you get from your institutions, or maybe students once you get there, about how well you're doing. Are you seeing the right number of patients? Are you billing and coding correctly? All of that is in analytics, and it's a lot of good data there. And I guess another horizon is predictive analytics. Predicting what patients are going to develop is far better than waiting for that development of a disease, because you're going to really solve a lot of problems and probably minimize the expenditure on the system.
It's interesting, and you're probably involved in this, but I just did a story on Cleveland Clinic partnered with the National Football Players Association to do exactly that. They're going through all the EMRs and trying to find out which patients using predictive analytics may be at risk for dementia, Alzheimer's, Parkinson's disease.
Absolutely.
So it's being used right now, right up the street, actually. Can you discuss your thoughts on the medico-legal aspects of physicians working with AI?
So, yeah, I mean, obviously there's concerns. If you're fully reliant on a technology, could you be at risk for legal liability if something goes wrong? I think that's true, and it's not true. I mean, no one blames you because the EMR said something. I mean, we use technology every single day in practice. It's unavoidable. Very few people are on pen and paper at this point. But I think it takes the legal team of the solution you're using, plus the legal team of whatever institution, or if you're a practice, a lawyer that looks over are you using the technology appropriate? Are you using it within the scopes of what it was intended for? If you start going beyond what the scope of that technology was meant for, then I think you're putting yourself at risk. And I think when the regulatory bodies are looking at this, there is some legal concern here. Is this putting individuals at risk for utilizing this technology? They're not going to put something out there that they think is blatantly going to be, blurring that line. But I think there's no stopping the technology juggernaut. We see it now. It's really changed our life. Anyone who's practiced for the past 20 years has seen dramatic changes in how they practice healthcare. And it's not going to get any less. It's only going to increase and probably be hopefully more efficient and more effective. But there's risk, but it's hard to, it depends on the solution too.
To what extent does your IBM experience influence and enhance your teaching of medicine students?
I'm definitely aware to be more patient with technology. I feel, again, I thought it was going to be something easy to fix, easy to change, but it takes a lot more effort and time. I do teach here at the medical school at NEOMED. So when I have a chance and we just kind of go off topic with whatever we're talking about, I do bring up technology issues and the importance of understanding the technology. As a clinician, it is your responsibility to understand how to use the technology, right? I mean, there's a manual that no one reads. You get a little bit of instruction that no one pays attention to half the time, but it's really the responsibility of the individual who's using that technology to make sure they're using it appropriately and very effectively. But I encourage students all the time to go out and read stuff about artificial intelligence, healthcare issues, the blockchain issues, quantum, because I think it's going to be their future, especially for students. I'm in the second half of my career, but I think for younger folks, it's definitely part of their career.
Are any pathologists or radiologists working with the IBM team? And what do you suggest as options for retraining the displaced surplus pathology and radiology staff?
Well, I'm going to answer that yes, we have individuals from those fields working for the company and specifically in their solutions. I don't know if it's going to displace radiologists or pathologists, I'll be honest with you, because we already have a shortage. It's going to be 42,000 radiologist shortage by 2033. I'm not sure the exact number of pathologists, but the number is also not good. One of the problems with clinicians is, we're stuck, and this is a political thing, but we're stuck in a 1996 hold on how many residency slots we have in the United States. Congress has to approve additional slots for those to be created and paid for. And so we're not generating the number of physicians we need to generate to maintain the current growth of population since 1996. We have shortages across the board, and these fields are also pretty high, having a lot of shortages. When I look at a CT scan or a pathology, it takes a week to get a review back. It takes a week or so to get a report back. It takes a week to get, a biopsy result back. Should it take a week? Should that be the delay factor that we accept? Or do we use some of this automated technology to help expedite the care? Now, I don't think it should replace a human in making that final determination. Yes, this is abnormal or this is completely benign. But I think it could help expedite the workflow, to kind of speed up that process. And I think that's where it's going to go. Again, I will tell you worldwide, there's a shortage. There's a complete shortage. And so if this technology is not going to be used here in the US because people are hesitant, I know in third world countries, Africa, Asia, I've traveled to many of those countries, there's a huge disparity. They may have one primary care physician treating 100,000 people in that area. I mean, it's just astronomically terrible. So we have to find that balance to bring some sanity to the numbers.
We've had some great questions from our attendees, so I just want to throw another request out there. If anyone else has any questions, please just put it in the Q&A and I will be happy to ask Dr. Patel. I have another one. You mentioned that AI reduces bias, though at times it may cause bias. How does it add bias? Yeah,
so this is a good example. AI almost always reduces or eliminates bias, but I'll give you two examples of where there's been actually bias induced. So when we look at dermatology studies, to help detect melanoma, they're very accurate. I mentioned it earlier. It's either equivalent or better than the pathologist reviewing those slides or a dermatologist reviewing the skin lesions. But Those studies have been done in countries like the European Union, United Kingdom, Canada, Australia, New Zealand, and the United States. This is a population that's heavily white Caucasian. So that AI solution really doesn't translate to people with darker skin, maybe from Asia, Africa, and South America. So I think moving forward in those type of studies, we have to be very cognizant that the population being studied represents a more diverse population, so that solution can be used more universally. And so that's an area where bias was, unintentional. The second example is what Amazon did actually in 2015, or at least they reported in 2015. They wanted to hire the best talent, and they were going to automate the system completely. So they looked at resumes from the previous 10 years to find the best candidate for these top jobs at Amazon. Well, the resumes happen to be heavily male because this is a male-dominated field historically. So the AI solution learned to downgrade the word woman. So if you went to a women's college or you were on a women's sport team, you basically got downgraded because they preferred men in the AI solution. Amazon reviewed this, said, oh God, we can't do this, it's terrible. They stopped that, they disbanded it. But this is, again, as you're putting these solutions together, you have to have the right audits of what you're doing to make sure that the bias isn't created, right? And so this is an area where bias actually unfortunately got introduced.
Another question from our attendees. Do you think bringing the technology into these fields will increase medical student interest in these particular fields?
I think so. I mean, there's a lot of stuff, I was very happy. I love clinical practice. I love seeing patients, but this is a whole new world I never really thought of. And there's a whole world out there. There's a lot of need for clinicians within the pharmaceutical industry. There's a lot of drug development and research there. There's a lot of need in the insurance company industry. They need to have physicians. They need subject matter experts to really help inform them. There's a lot of need in technology companies to have the clinical experts who understand clinical medicine, have practiced a little bit, and then come back and give their expertise. So the solutions, they're creating are not for their mindset, but you as the clinician say, yeah, I think this is going to be a great solution. This is where the need is. This is where the gap in healthcare is, and this is what would really make it better for us. And so I think there's a lot of opportunities there. And even if they didn't want to go into other industries, they want to stay in clinical medicine, I think it's going to help them become clinical leaders within their institution, right? It's hard to become a clinical leader if you don't have a business background, an MBA, or have some other degree going beyond your MD or DO. I think it has to be there for individuals who want to go into administration, want to be leaders within the organization, because that stuff's not getting simpler. It's getting more technical. And it's getting more complicated. So if you can understand that, have the talk with the right folks, whether it's a clinical folk or a financial person or some sort of distributor or pharmaceutical company, it's going to make your life a lot better and make your ability to succeed a lot easier.
Does technology reduce the empathy of a practitioner for their patient?
Hope not. I hope it doesn't change who you are as an individual. I will say the clearest example of where you might see some lack of empathy, and you can see that from patient surveys, is the physician doesn't look at me, looks at his computer. That's what we commonly hear. So I think being cognizant of that and trying to adapt where, you can quickly type something and, keep that eye maintenance, but, obviously typing correctly, you don't want to enter misinformation in the computer, or learning to do that before or after the visit so you can really maximize that time. I do worry with technology, and I see, and I hate to say that, I see it with students where they're not that they cannot communicate, but they're a little bit more terse with the language and more like a texting format versus maybe a flowing conversation that I'm accustomed to being trained back in the 90s and so forth. But I think it depends on the individual. You have to really make sure that what you're doing, because it has to be for the patient, because that's your primary responsibility, is treating that patient and making sure you can give them the best possible outcomes and therapies that they need.
We've been receiving computer-based ECG interpretations for decades. The ECG notes unvalidated result for the interpretation until read by the MD. Is this early AI? And is this an example a lot of people would understand better?
Yeah, that is an early example of artificial intelligence. The EKGs come out, says left ventricular hypertrophy, moves on until a cardiologist signs off on it. It doesn't become official, but typically they're pretty accurate. Again, they're not 100%. There's some inaccuracy, but that's probably a very early example of AI. Absolutely.
When do you think this technology will be used routinely, and where are we in Northeast Ohio at our medical facilities using AI?
So we're using it pretty much now, but maybe not to the breadth of where it needs to go. So I think when we're looking at really moving into heavy technology and really moving us into the next era, age of technology, I think it's probably 5 or 10 years off. I don't think it's going to be a generation away. I think it's going to be fast and furious. I know the companies are working very hard to bring this technology, but technology is with us. And a lot of it we don't recognize as technology. It's the little things that we don't see. That does the things that clinicians see most and clearly is the EMR system in front of them. That's the technology they see most, but there's so much behind the scenes in the structure of a hospital.
Here's another interesting question. Will AI ultimately change the way students are being tested?
Well, that's a good question. I'm not sure. I don't know if you want the AI to do that. You might want the human compassion to kick in because, there's a little bit of less, AIs are not known for their compassion, but it could be. I actually don't know for sure, Monica. I think you still have people reviewing the questions and making sure they're appropriate for what's been taught at the institution where they are. But I can't imagine the AI taking that over 100% with no human input. I just don't see it.
I think that's why we still need to learn math, because we can't depend on calculators, so kind of the same thing. If anyone else has any other questions, please ask. We just have a few more minutes left. How does quantum computing benefit healthcare and outcomes?
Yeah, this is a great question because I know that announcement was a few weeks ago in the Cleveland News with Cleveland Clinic and IBM partnering for the Discovery Accelerator, looking at quantum computing on site at the Cleveland Clinic, which I think would be the first quantum computer at a private industry in the nation. So quantum computing is unique because I'm going to step back a little bit and talk about advanced supercomputers. When they write code, it's binary, it's zeros and ones. You can have one of two states. But with quantum computers, they don't use these bits. They use something known as quantum bits, which we abbreviate to qubits. And so the qubits can exist as 0 or 1, or they can exist at multiple states. So it's not just a 0 or 1, but it can exist at multiple states. So an example of how that might work, that might be understandable, if you look at a maze, you have a complicated maze and you tell the supercomputer, go through the maze and find the path that will get you to the exit. It's going to go through every single pathway until it has the right one, and it's going to graph that out, but it's going to go one by one. Whereas the quantum computer is going to run through the whole thing at one time and be that much quicker and get to the end. So when we look at a quantum computer, when you flip a coin, another example, when you flip a coin and it floats in the air and it's coming down, you're going to think, oh, it's going to be heads or tail. And the supercomputer, to be able to program to see what it's going to do, there's so many variables, it takes a long time. But the quantum computer can visualize where it is, where it's going to be going, and when it's going to come down. And so it can do that multiple states. It's able to function in states of uncertainty. And so that gives the speed and the strength of the quantum computer to do far beyond any supercomputer. And where I see that in healthcare specifically is looking at drug discovery, genomics, I mentioned this earlier, single cell transcriptomics, and population health, where there's so much data intense information that it's hard for a supercomputer to really figure that out. It's going to be the quantum computer, if they can get that right, where that's going to occur. And I think quantum right now in healthcare is at the earliest nascence of use at this point. I think we're going to have to wait it out a few years, let them figure out what the right program to put in there, and then we're going to see the benefits. And I think that's what Cleveland Clinic is really hoping. And I know with that relationship, they're going to get a 1,000 qubit system. Typical systems are 50, 60 qubits right now. So that's a very powerful quantum computer. And I know a second one is going to come in 2023. I remember somewhere in the Cleveland downtown market. But quantum computer will really change things very quickly if they can get it right.
Oh. Well, we are out of questions at this time. Would you like to offer any final thoughts before we hand it back over to President Langell?
Yeah, no, again, thank you, Monica, for the moderation. Thank you, Dr. Langell and NEOMED. It really is a privilege to be able to ask to come talk about technology. And again, there's not a lot of time. Technology is very broad. It's hard to go into great depth about one topic, but I would encourage anyone who's very interested, please go out and seek that information. It's on the internet. You can always reach out to me if you have additional questions. But I do think it's really the future of how medicine is going to be practiced. But I would encourage you to be passionate and empathetic for your patients, because I think whatever we do has to be for the patient and the outcome. It has to be the final part of what we do.
And hold that thought. We got one final question that just came in. AI and analytics seem to rely more so on pattern recognition when mining information. But in using past data to create AI recommendations, it would have to make the assumption that the prior data analyzed is both complete and accurate.
Right.
How can we be confident that what the machine is learning is coming from an accurate and relevant database? Can we be confident of it not to create recommendations that don't neglect differences among populations, race, gender, age, and etc.?
Sure. So I think this was the question related to the external control arm, specifically coming from a prior data set. So you're right, a computer draws it out, but there's a lot of missing data points, especially with older records. So unfortunately, that still requires a lot of manual chart review or manual review of the system to make sure you're getting the right data points. Because for trials, the FDA is not going to approve that trial if the data points are missing and that data is not appropriate. They will not approve that to be run. When we're looking at predictive analytics, this is why it's very difficult to do in-house. You have to try to utilize not just your institution, but you have to have several or multiple institutions or many institutions, the data coming in, because the more data you get, the more accurate the predictive analytics can be. But there's so much concern about, I'm going to lose patients to my competitor if I give out my information. What if there's a breach of data, there's a HIPAA or a GDPR violation? What does that mean for my organization? There's a lot of fear there. But I think if we can get past those barriers and we can really put a lot of the data together, because there's a tremendous amount of data out there, we will have accurate predictive analytics and whatever we're looking for, whether it's disease progression modeling or population health issues and so forth, or even looking at the trials. It's possible. It's just, can you get the right data for it?
Do you have a NEOMED email that you could share for people who would like to get in touch with you again?
Sure. Let me think of it. It's yeah. Do you want me to say it right now? Or it's fine.
Yeah, or we can put it on the Facebook page.
Oh, sure. Yeah, it's mpatel@neomed.edu, and I can tell you, I was the first class to get email when I was here, so that was a long time ago.
No, don't admit that. What?
When I was in college, I didn't even know what email was, so that's how bad it was.
Yeah, that was me 20 years ago. So.
You're too young, so.
No, yeah, very kind. Thank you. All right, I'm going to hand it back over. Thank you, Dr. Patel. This was really, really enlightening. I'm going to pass it back over to President Langell.
All right, thank you very much.
Thank you, Monica. Thank you for that expert moderation as always. And Dr. Patel, really thank you for introducing this critical topic, artificial intelligence, quantum computing. It's the now and it's the future. And if you really want to lead in healthcare and make a difference, I think it's incumbent upon us to really understand this technology. Dr. Patel, amazing. We're really thrilled to have you as part of the university and to have our students benefit from everything that you bring to the table for us. VITALS will be on summer hiatus. Please visit neomed.edu/vitals to watch this past year's master sessions by our nation's most innovative leaders. We'll see you again in September when we bring you more VITALS, visionary health, leadership, and action. Until then, please be safe, and we look forward to meeting again.
Health outcomes, changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even few are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.